If you thought the GLP-1 era was already impressive, what was presented at the American Diabetes Association or ADA's scientific sessions just last week might be a glimpse into the next generation of obesity treatment. One of the biggest stories coming out of the ADA 2026 was the phase 3 data on retatrutide. Retatrutide is different from medications like semaglutide or tirzepatide because it targets not one, not two, but three different hormone pathways: GLP-1, GIP, and glucagon receptors. That's why you'll often hear it called a triple agonist. And the results were remarkable. In the Triumph 1 trial, adults with obesity receiving the highest 12 milligram dose lost an average of 28.3% of their starting body weight over 80 weeks. For many participants, that translated to about 70 pounds of weight loss. Even more impressive, roughly 1 out of every 3 people lost more than 30% of their starting body weight. But here's what I always tell my patients: obesity medicine is not just about the number on the scale. And what really caught my attention was the improvement in obesity-related diseases. First up, retatrutide reduced obstructive sleep apnea-related breathing events, their AHI, by more than 60%. It also significantly improved knee osteoarthritis pain, which makes sense because losing weight can reduce stress on the joints, but there may also be an anti-inflammatory effect at play. The cardiometabolic data were also impressive. Participants saw their triglycerides fall by about 41%, their non-HDL cholesterol decreased by more than 24%, and systolic blood pressure dropped substantially as well. In the obesity trial, the highest dose was associated with an average systolic blood pressure drop of over 12 points. Some other studies suggested that many patients were able to reduce or completely come off at least one blood pressure medication during treatment. Researchers also reported dramatic reductions in markers of systemic inflammation, including your high sensitivity CRP, reinforcing something we've known for a long time. Obesity is not simply an issue of willpower, it's a chronic metabolic and inflammatory disease. Now, let's talk about safety. The side effects profile looked very similar to what we've seen with other medications in the same class. The most common issues were nausea, diarrhea, constipation, and vomiting, and these were generally mild to moderate and improved over time. Like other incretin therapies, there can also be a temporary increase in heart rate during dose escalation, so careful monitoring remains important. It's also worth remembering that these are conference data, right? And ongoing studies are still happening. Very interestingly, there are active trials comparing retatrutide directly with semaglutide and evaluating its role in people with type 2 diabetes and chronic kidney disease. The other interesting takeaway from the ADA this year is that the obesity treatment landscape is becoming increasingly competitive. Novo Nordisk presented phase 3 data on their CagriSema, showing around 23% weight loss, and there were other investigational medications that were also showing promising results. We're moving into an era where obesity treatment isn't just about helping people lose weight. It's about treating sleep apnea, osteoarthritis, hypertension, dyslipidemia, inflammation, and potentially reducing long-term cardiovascular risk, all with one therapy. Retatrutide is not FDA approved just yet, hopefully by early 2027, and we still need longer-term data. But if these findings continue to hold up, this could represent one of the biggest advances we've seen in obesity medicine thus far. And I think that's the real headline from the ADA 2026. We're no longer just talking about weight loss. We're talking about changing the entire trajectory of metabolic disease.